So these are my disclosures, which not interfere that much my talk. And again, what is MIS concept? It is actually a broad term which is defining the implementation of surgical routes like percutaneous stab incision or Wilson mini-open approach, together with dedicated tools like navigation and robotics, or MIS screws, or MIS solution, hybrid solution for anterior reconstruction, and may allow to reduce the invasiveness of surgical procedure. And then probably there is no other field of spine surgery where the MIS can be implemented with very good results as in the thoracolumbar trauma or the spinal trauma, generally speaking. But why MIS? We all know that using MIS, we can minimize the soft tissue disruption, we can minimize the stabilization of spinal segments. We may obtain also lesser estimated blood loss, shorter long length of stay, together with the recovery time, which is shorter and accelerated with less postoperative narcotic use. It fits very well the concept of enhanced recovery after spine surgery, and it might be applied to posterior, anterior, and lateral approaches to the thoracolumbar spine. Of course, there is plenty of evidence in literature about implementation of MIS approaches in thoracolumbar fracture. Here, for example, a very nice comparison between three groups of patients: open MIS with a short fixation, which means 4 screws, and MIS with longer fixation, which is a screw in the fractured vertebra as well. And there is a significant difference in favor of MIS groups when compared to the open, and there is no significant difference when you compare the MIS 4 screws, 6 screws, but it seems that there is a better kyphotic correction in MIS groups with a longer fixation system, which means with intermediate screws at the level of the fracture vertebra. And there is also evidence comparing the Wilson approach, which means mini open without stab incision at the skin, compared with the open approach. Here on the left, a study showing that using the Wilson approach allows for a reduction of postoperative pain, lesser intraoperative blood loss, shorter operating time, and shorter length of stay. And also studies using an MRI in a postoperative period, for example, they are able to show that with the Wilson approach, the mini open, we might have less incidence of multifidus atrophy and denervation, and less fatty infiltration at levels, increasing the stability of the muscles in the postoperative period. And it is a matter of debate if you should use a percutaneous stab incision or a Wilson approach. And I would say that I do prefer the Wilson approach to the percutaneous stab incision. It seems that the open Wilson might be a better choice by decreasing the facet joint violation, because you can palpate actually much better with your fingers the entry point in order to respect the facet joint for the vertebra at the level above and below the construct. And there is a better improvement also in postoperative vertebral body angle when compared to the percutaneous with stab incision. So despite the benefit of MIS in thoracolumbar junction, thoracolumbar trauma with percutaneous and open, and despite the fact that we know that there is no significant effect in complication rate, ODI, a radiological outcome when you compare percutaneous versus open, the main drawback of percutaneous, at least the standard old-fashioned using a fluoroscopy, is actually the increase of the fluoroscopy time and radiological exposure that, of course, today are very much improved by the use of navigational robotics. Here, for example, series by using with the use of the O-arm navigation, showing that the navigation will add benefits to the MIS concept, increasing the accuracy of the screws with a lower functional perforation and or radiological perforation and breaches at the level of the pedicle. And on the right, there is also the use of electromagnetic navigation with, again, a better placement of screws, lower radiation exposure, and lower operation time. And again, there is literature concerning the use of navigation both in percutaneous stab incision and the Wiltse approach, and the conclusion is over the same, that with the use of navigation, we have less radiation exposure and better wound healing when you use especially Wiltse approach when compared to percutaneous, and of course increases the accuracy of screw insertion. Robotics is just joining the field of thoracolumbar trauma, and there are series showing that apart from the benefit which are the same that navigation, there is also a reduced facet joint violation and a more stable tool insertion and reproducibility of good results with a robotic end and support. And there is also a study with a short clinical series of 14 patients operated with the robot, showing that there is an interest and there is a learning curve, especially for the first, I would say, 5 to 6 cases, when then you become much faster by using robotics to operate thoracolumbar trauma. But MIS concept can be also applied to a lateral solution for thoracolumbar trauma. Here, MIS corpectomy with dedicated retractors, which might be also associated to percutaneous or mini open posterior thoracolumbar fixation with screws, one screw above and one below. And of course, we can use dedicated cages with very large end plates, providing an anterior support. And it seems that here, this kind of solution, of course, leads to increased lordosis with a significant restoration of the anterior height of the vertebra and correction of kyphotic deformity. The same for endoscopic solutions. This is also MIS applied to thoracolumbar trauma. Here, a very important series of 371 consecutive cases treated by thoracoscopy, most of them with posterior implants, some of them without, and with all the benefits of thoracoscopy compared to the thoracotomy, which is less blood loss, faster recovery, and a good realignment and kyphotic correction. Here, for example, a case we did an A3 fracture with posterior tension band involvement, so defining like type B2 A3 our spine fracture at the thoracolumbar level. We did the posterior percutaneous realignment and the expansion of the vertebra, and then we went to the front as suggested by Bassi in 2007 with the thoracoscopy with 4 stab incisions, and we went lateral to the spine, introducing a bone graft from the left side in between the two involved vertebra, and with a good fusion at the end. And the idea is also to remove the lower part of the construct to increase a bit the mobility 1 year after surgery. There is a big interest in hybrid techniques. We dramatically reduced the number of corpectomies thanks to the introduction of these stentors of these spine jacks, and we very often combine the posterior reconstruction with the percutaneous or Wiltse approach, together with anterior restoration of vertebral body with the spine jack and kyphoplasty and cementoplasty of the fractured vertebra, of course, with very selected cases. The use of navigation, robotics, or whatever, so requires also very important operating room setup changes. And so we needed to adapt and to train our OR staff to really have the best solution for the OR setup. Here, how we actually use and implement the navigation in a thoracolumbar standard approach, posterior approach, the position of the tower, the navigation camera, the monitor. And so this should be extremely obsessive compulsive if you want to reduce the length of the duration of surgery and improve the workflow of the surgical room. This is like it is extremely crowded with the 3D isocentric C-arm to do the acquisition, the brain lab navigation, the camera, the monitors, and of course the instruments and the hardware. So what I do suggest to the new users for navigation to use for each case of thoracolumbar fracture as a routine basis. This will make your life much easier, and you will be happier. You don't need to fight with OR staff which is not used to implement this kind of new technology. In conclusion, take-home messages, I would say that MIS applied to thoracolumbar trauma allows for reducing invasiveness of surgery and accelerate post-operative recovery. Navigation and robotics facilitate implementation of MIS in thoracolumbar trauma. And of course, the main advantages is increasing of skew accuracy and drastic reduction of radiation exposure and the facet violation rate, which seems to be associated with an increased rate of adjacent segment disease. And I thank you for your attention.
Thank you very much, Professor, for the very informative talk and about all the innovative technique that you have presented to us. Any questions for Professor Tessitore?
I think
Can I ask a question to Enrico?
Hi, Andreas.
Enrico, thank you. Very good as always. In the situation where you want to do an MIS approach, but feel you also need to do a decompression, will you do an open or will you do MIS for the screws and separately mini open?
Very good point, because it brings up also to the discussion of the need of decompression in thoracolumbar trauma. And there is an evidence that the probably indirect decompression by realignment of the spine and the correction of the kyphotic deformity really reduces to very few cases the need for a direct decompression. But as soon as there is a need for a direct decompression, I would not hesitate to go from the back to do the decompression in open and to put one screw above and one below. And then if there is a need for anterior reconstruction, to stage the surgery and go for an anterior reconstruction with a corpectomy. In most of these cases where do we need to decompress, there is a major blowout of the vertebra, huge fragments of the canal, CSF leakage, disruption of the dura mater, very severe spinal cord injury. So I would not hesitate to go open and to really decompress as much as possible, again, if needed. Otherwise, in most of the cases, we do rely on indirect decompression by ligament ataxia and correction of the deformity.
Thank you, Enrico. And I have another question for you, if the chairman will allow me, Aristide.
Of course.
Another unsolved controversy in this region is whether we should remove the metalwork. And I don't routinely remove metalwork. I always offer it to patients and tell them it's a possibility down the line. But most of the time they say no, and I haven't really had any persistent problems with that. Do you remove it routinely or sometimes or never?
We did remove in the past. By shortening our construct, we do remove much less, which means that in the past when we did the 2+2 or 3+2 only posterior only approach, we had the tendency to remove as soon as the fusion at the fracture level has been obtained. But nowadays with the short construct, one level above and below, an anterior reconstruction, which is by stenting or spine jack or corpectomies, we do not remove the implants, because then only actually segment where you regain mobility is the disc below. And so with this kind of short construct with anterior reconstruction, we do not remove, apart if the patient seems to be hurt by the head of the screws with local specific pain, then sometimes we do remove, otherwise we don't.
Thank you.
And I have a question as well, Professor. In your daily practice in your department, in what percentage do you utilize minimal invasive techniques and open techniques in thoracolumbar trauma?
Again, I would say roughly like this. I do not have numbers to give to you, but the MIS, probably I do use more MIS in trauma than in degen. And with regards to trauma cases, I would say that we go 7 MIS and 3 open. That's more or less the ratio.
Any other questions?